Now, why this question? Because 70% of the patients who present with a hip symptom for a arthroplasty surgery, they have somehow or other some spine symptoms coming from the back. And that is where the confusion arises, that whether to, do the spine first or the hip first. Now, it is all about perspective, how you look into it. How a spine surgeon looks at it or how a hip surgeon looks at it. But both the surgeons should, remember there is a patient in between, and you have to look from patient's perspective as well. Because what the patient wants and how far he is symptomatic and how far you will be better off from the present scenario after your surgical intervention. So it requires a multidisciplinary approach, or as you can tell, multi-speciality, subspecialty approach. That how you look into it. If you look it from the front or you look it from the side, the things are different. So from the hip perspective or from the spine perspective, it will look different, but you have to take a decision ultimately which will be useful for the patient. Now remember, hips don't lie, neither does the spine. They go together. Hip, spine, they are not a separate entity. In your day-to-day activities, hip and spine, they act together. And in your sitting, standing position, even if your activities which are not your day-to-day activities, even your evening activities, whatever, your hip, spine, they work together, and hence you have to think both together. So the burning question, whether to go for the spine first or the hip first when the patient comes to you. Now traditionally, the priority has been, it depends on the severity and the location of the symptoms. That is, if the spine symptoms are more severe, then you do the spine first, or the hip symptoms are more severe, do that first. And now what is the activities of daily living of that particular person, and what is the preference of the patient. So these are three things which you used to decide that, what you are going to do first. But for the last couple of years, all these things have come into our armamentarium. So three important things which one must know, that what is known as sacral slope, which is, a line drawn along the superior end plate of the sacrum and how much angle it makes with the horizontal, that is the sacral slope. This is pelvic incidence, and this is a perpendicular drawn from the sacral slope or from the upper end plate of the sacrum, and a line joining the midpoint of the sacrum to the center of the hip. So the angle between these two lines is the pelvic incidence, and this is pelvic tilt. That is this line, how much angle it makes with the vertical. So in whatever positions, your pelvic incidence will be the summation of pelvic tilt and the sacral slope. That is the basic, fundamentals of all these things. That's the basic fundamental of this, how you are going to treat it. So when you are, standing from a sitting position, okay, when you're standing from a sitting position, your lumbar lordosis gets reduced or gets obliterated to a certain extent. When there is a decrease in the lumbar lordosis, there is a decrease in the sacral slope as well. So in order to maintain that pelvic incidence, your pelvic tilt increases because the summation has to be equal. So then the opposite thing happens when you are going from sitting to standing position, that your sacral slope increases and pelvic tilt decreases. So whenever there is an increase in the pelvic tilt, there is increased acetabular anteversion. That is why, because naturally your head is a big head, and that should not impinge when you are sitting. So to prevent the impingement of that head of the femur, there is increased acetabular anteversion. So from standing to sitting position. But this thing doesn't happen when your spine is a stiff spine, like a spondylosis or advanced degenerative changes, or if there is ankylosing spondylitis, or if you have done a spine surgery, have done a lumbosacral fusion, this change doesn't happen because there is a fixed acetabular anteversion. Because the sacral slope doesn't change from standing to sitting position, and because the sacral slope doesn't change, so pelvic tilt doesn't change, and hence there is no increased acetabular inclination, anteversion. So when there is no increase in acetabular anteversion, so whenever you sit, there are chances of impingement anteriorly. And if you have done an artificial prosthetic hip joint where the head size is smaller, because of impingement, and there is, the jump distance is less, and there is a chance of posterior dislocation because of impingement. That is where all the crux lies, that how to do it. Now let us go through a couple of papers. So these are the same group of authors who have published two papers. First, they published that whether to study that what is the effect of lumbosacral fusion first, followed by total hip versus total hip alone. And it has been seen that patient get more pain, there is a worse, VAS and satisfaction scores if you do the total hip replacement after lumbosacral fusion. Then the next year itself they published that if you do the total hip first, then you do the lumbosacral fusion, there is also worsening of the back pain, mobility and return to usual activities and function. So both the things gives rise to a worse outcome and whether to do this thing or that thing first. So what happened in the hip society, they did a survey. So they asked the questions to the spine surgeons as well as the hip surgeons, and they published it. This is the survey, and they found 5 hypothetical questions or fictional scenarios, like lumbar canal stenosis with neurological claudication. Second scenario, lumbar degenerative spondylolisthesis with leg pain. Third is lumbar disc herniation with leg weakness. Fourth is lumbar scoliosis with back pain. And finally, thoracolumbar disc herniation with myelopathy. Most of the patients, they fall into these groups, one of these groups when they present with the hip pain. And most of them, they decided or they opined that with progressing scenarios from scenario 1 to scenario 5, the percent of surgeons, they opine that hip should be done. So scenario 1 and scenario 2, the hip should be done first. Whereas scenario 4 and 5, the spine should be done first. Whereas the scenario 3 is a gray zone, where the surgeons, they differ in their opinion. Some surgeons felt that spine should be done first. Some surgeons felt that hip should be done first. So let us go through if you are doing a lumbosacral fusion and doing a total hip arthroplasty, let's go through the papers from Arthroplasty Journal and the Spine Journal. So this is Arthroplasty Journal paper. When you do a lumbar fusion before doing a total hip arthroplasty, it is an independent risk factor for dislocation leading to increased risk of revision. And there are scores of papers. Another paper in 2019 also shows prior lumbosacral fusion undergoing total hip arthroplasty has significantly high risk of dislocation and subsequent revisions compared to total hip done followed by lumbosacral fusion. Whereas the spine people published in spine journals that if you do a total hip replacement before the lumbosacral fusion, that has got a highly significant increased risk of postoperative dislocation. That is again, contrasting views in both the journals or both the groups of surgeons. So in most cases, hip was done first, followed by the spine, except the patients which have got adult spinal deformity and there's an unbalanced spine. So first convert the unbalanced spine to a balanced spine, and then you do a hip replacement. So dear friends, after all these things, are you more confused than before? So let me get some message for you at least. So the nature and severity of neurological symptoms is the decision-making factor in deciding which one to be done first. The more time-sensitive issues like myelopathy and weakness, in these kind of cases, the spine should be done first. But if there is only leg pain or neurological claudication, then the hip should be done first, because they are probably eventually they are going to improve after the hip surgery. Those some of the papers they show that spine symptoms they improve after the hip surgery, but it has not been proved in proper prospective randomized control trials. But if you are doing the hip first in presence of leg pain and neurological claudication, one point that one should think about, if there is a motor loss, then the motor loss may lead to permanent disability over the period of time. In those kind of cases, one has to consider the spine first. So if there is a imbalance in the spine, first balance that spine and make it rigid, then go ahead with the hip surgery. But if at all, if you are going to do the hip surgery first in an imbalanced spine, then think of using a larger head or dual mobility cuffs, which have got less chances of dislocation because the jump distance is less. And in this particular order, myelopathy, weakness, neuroclaudication, radicular pain, these are the decrease in order of severity, which decides you that in more of myelopathy and weaknesses, you must go for the spine surgery first. And if you have neurological claudication, radicular pain, think of doing the hip first, unless there is a motor weakness. So, but men will be men. And as orthopedic surgeons, or just as orthopedic surgeons also will be orthopedic surgeons. And they always think that because an orthopedic surgeon, you will do what you want. And kabhi kabhi lagta hai, apun bhi Bhagwan hai. So whatever you decide, you think that patient will follow. So I thank you for a patient hearing. But remember, again, last message what I told first, whether spine surgeon or hip surgeon, the middle person is the most important person, that is the patient. So you must consider the patient perspective that he or she is the most important person. Dear friends, in front of this, learned audience, I never came to ask you a question that do you have the spine to the hip first? I just came to you to humbly request you for supporting in my elections in the Indian Orthopaedic Association, contesting for the Vice President of the Indian Orthopaedic Association, and I need your support. The elections will start from the 1st November till 22nd November. I thank you for a patient hearing.